going to do a review for your quizzes tomorrow. After I do the review, then we're going to, I'm going to have you subculture. I got some McConkey and blood agar, real McConkey and blood agar, and I'm just going to have you streak 2 organisms, Staph and Pseudomonas aeruginosa. So you can see what the colony morphologies look like. We're having trouble getting media in, so we're just going to streak on those 2 plates. Going to have tomorrow, you're just going to record your observations, and that'll be it for lab, and then you'll take your quizzes. So short lab today, short lab tomorrow. All right, so antibiotic susceptibility testing. Why do we want to do antibiotic susceptibility testing? Anybody have any idea? Why do we do it? Why do we do it? What are we testing for? Rudy? Treatment of the antibiotics, right? So the doctor knows what antibiotics to treat the patient. What else is it about? What other information can the doctor get from the laboratory with the information like antibiotics? Say again, ID? Identification? Okay. What else? What is it? Okay, let's focus on the antibiotics. Is he going to just give any up? Go call the pharmacy and say, I need tobramycin, I need vancomycin. What is it that the doctor has to coordinate with the pharmacy to help treat this patient? Say that again. Susceptibility. Yeah, sure. Yeah, susceptibility testing. That's the whole focus of this lecture. Whether or not, when you say susceptibility, what exactly do you mean? Will the organism survive, or is this antibiotic going to be effective? Is that what you mean? Or will it be not effective? Okay, so in the laboratory, we can tell whether or not the doctor is going to be using, the doctor doesn't want to give an antibiotic that's resistant to a certain antibiotic, right? Because if it's resistant, that means that the bacteria, the organism will survive. If it's susceptible, that means the organism will not survive. That means it's susceptible, it's sensitive. So susceptibility testing or sensitivity testing, they mean kind of like the same thing. Either way, the organism will not survive. One more question, which I was kind of alluding to. Say, for example, a specific antibiotic is effective, or against an organism, it is susceptible. But what is it about the antibiotic that the doctor's going to want to zoom in on treating this patient with that particular antibiotic? Yes, dosage. Tell me about dosage. Right. So I don't know in chemistry if you guys have done peaks and troughs. Did you guys talk about antibiotic peaks and troughs? In chemistry, the analyzers will do, especially in immunochemistry, depending on the analyzer, you'll do vancomycin levels or tobramycin levels or amikacin levels. Usually it's the aminoglycosides, and that's what those antibiotics are. If one of the things that the doctor will order from the ward, and usually patients, an inpatient, or they could be an outpatient, are peaks and troughs. Have you ever heard of peaks and trough levels? Okay, I'm going to get into that later on. So I'm going to get into that later on, but you're right, Jeremy, dosage is correct, because if you don't give a high enough dose that you know this antibiotic is susceptible to, if you don't give a high enough dose, then what the pharmacy does is they take information from the patient, like how tall are they, how much they weigh. Based on the patient's metabolism, that antibiotic will have a shorter half-life. So if the patient has a high metabolism, then the antibiotic won't last long. So if the doctor orders Q 12 hours, you know what I mean when I say Q 12 hours, right? Every 12 hours, you're going to give a dose of antibiotics. So what he'll do is that the trough level is the level of antibiotics 30 minutes before the dose is given. The trough level is the antibiotic dose before the dose is given, okay? And then the peak level is 30 minutes after the dose is given. What's more important between the trough and the peak is that okay, so you give a dose, 12 hours later, you're going to get another dose. But before that second dose, 30 minutes before that, the pharmacy is going to tell the lab, I need a trough level before this next dose. If the dose is high enough, then the pharmacy says, okay, you got the correct dose. If it's too high, then it could be problematic for the patient, where you may start, it may be high enough, too high, then it might affect the kidneys. We don't want it too high. We also don't want it too low. So what's happening is that the pharmacy is trying to calibrate what's a good enough dose. If the trough level is essentially 0, that means the patient's metabolism was so high that the antibiotic is already gone. So by the time the antibiotic's gone, between that time and the time of the next dose, the patient's not protected. So what's going to happen is the pharmacy is going to increase that dose. So that's a little bit on peaks and troughs. I'll try to talk about it later, but the pharmacy works with the laboratory and the patient to let the patient know that, okay, you're going to have more labs, and they're going to try to zone in on what is the appropriate dosage. Because if the patient's metabolism is too high, then that antibiotic dose is not high enough. So they're going to increase the dose of that antibiotic so that you'll get a detectable level of antibiotic, okay? The peak level that just tells you 30 minutes after the dose is given that the antibiotic's at a certain level. That's given. After you give a dose, it's going to be high. The important one is the trough level. You need to have at least detectable and effective level of antibiotic before the dose of antibiotics given. So let's go ahead and start on this lecture. Okay, I talked about susceptible. Susceptible is the same as sensitive. If an organism is susceptible or sensitive, that means it's affected, and it'll have inhibitory action, the antimicrobial or the antibiotic. If I say antimicrobial, that's the same as antibiotic, okay? So susceptible is affected by the inhibitory action of an antimicrobial. Okay, so they're susceptible. And then, like, I'm going to get into MICs, which is minimal inhibitory concentration, and MBC, okay, bactericidal, minimum bactericidal concentration. But in general terms, susceptible and sensitive means that the organism is affected by an antibiotic. Resistant means that the organism is not, affected, it's able to withstand the inhibitory effect of an antimicrobial. And then intermediate is based on the CLSI guidelines, it's either susceptible or resistant. CLSI stands for Clinical Laboratory Standards Institute. They're the ones that standardize what are the limits for susceptibility and what are the limits for resistance. Okay, so for example, we're going to get into Kirby-Bauer zone sizes. Certain zone sizes are defined by the CLSI, Clinical Laboratory Standards Institute, that will tell us whether or not the organism is sensitive or susceptible or resistant. We're going to be doing Kirby-Bauer testing next week. I wanted to do it this today, but I wasn't sure if I was going to have media prepared. Okay, so intermediate is in between susceptible and resistant. So if the laboratory tells the doctor what antibiotics are susceptible, those are the antibiotics that he's interested in. If, for example, say, for example, the patient is allergic to penicillins or anything that's penicillin, the organism can be susceptible to the penicillins, but it's not a good antibiotic to give to the patient because of the allergic possibility of an allergic reaction. So what he may consider is the next consideration would be if the organism was intermediate. Okay, so intermediate is okay to give to the patient if all options for susceptible antibiotics are off the table. You see what I'm saying? If the patient is allergic to the penicillins and your antibiotic testing shows susceptibility, and if the patient's allergic to the penicillins, he's going to go to the next best option, and that would be any antibiotic that would give an intermediate reaction. So intermediate is not necessarily good. It's not optimal, but it's an acceptable alternative. Antimicrobial and antibiotic, those terms are interchangeable. Natural or synthesized substance used to inhibit or kill agents. Okay. Bactericidal is an antibiotic or antimicrobial that kills infecting agents. Bacteriostatic, basically, it doesn't kill, it just inhibits the growth. Okay. The types of AST is you got diffusion test, broth dilution, agar dilution, and specific resistance tests. The top two diffusion tests, that's the Kirby-Bauer method, and the broth dilution is the MIC method. So if we do the Kirby-Bauer method, in terms of terminology, you're looking for sensitivity. If you do the broth method, then you're looking at susceptibility. Okay. As microbiologists, that's how we tell the distinction. If they say do a sensitivity test, the doctor say he's going to want to do a sensitivity test. The microbiologist will say, okay, we'll do a Kirby-Bauer. Kirby-Bauer is when you do the plated method, and then he'll say, what is the MIC result? And that's the result that comes out of a machine or a tube dilution. They don't do tube dilutions in the laboratory. They have automated instruments that will actually have dilutions performed, and it'll give out an MIC result. And then there's agar dilution. That's an antiquated procedure, and then specific resistance test. And I think that's called the Schlichter test, and it's kind of a reverse sensitivity, and I'll talk about that later on. Okay, so you see that plate there, and you see those zone sizes. Those zone sizes are the zones of inhibition. And the reason why there's no growth in these areas is because that's how far the antibiotic has diffused out into the agar radially. Okay, so this particular antibiotic had diffused out into the agar in this radial fashion, in circular. So if it was square, you would get squares, but because the impregnated disc is circular, then you see the circles. So here we see sensitivity. Sensitivity, those are zones of inhibition. In the zones of inhibition, there's no growth. In this case here, where there's no zone of inhibition, this antibiotic is demonstrating resistance. Okay, has no effect. This antibiotic has no effect on the organism. So the organism is happy and it's not affected by this antibiotic, as opposed to here, the organism is affected. And as you can see by the zone sizes, you got inhibition of growth. Okay. So these antibiotics kind of simulate in vitro the medicine or whatever you get from the pharmacy. So this can be like amikacin, it could be vancomycin, it could be nitrofurantoin. You're not going to put those pills on here. So here you have representative on these impregnated discs, you got concentrations of these antibiotics on here, and it's kind of like simulates how the bacteria, how the organism will react to those antibiotics. So this is kind of an in vitro assessment on the effectiveness of certain antibiotics. Okay. And like I said here, like the antibiotic or antimicrobial is impregnated in these filter paper discs. So you place it on the agar media, you tap it so it sticks onto the media, and using I'll be giving you charts and that will tell you whether or not, depending on the zone sizes, the organism is sensitive or it's resistant. Okay, so this diffusion test, it's designed for rapid growers. Usually 24-hour overnight incubation is what we're looking for. Commonly done for, and when I say disc diffusion, that's the Kirby-Bauer method. Commonly for Enterobacteriaceae, I'm going to start lectures on the Enterobacteriaceae tomorrow. Staph, strep, Pseudomonas, Enterococcus, Haemophilus, and Neisseria. Those are two very fastidious organisms, and they have to be incubated in CO2 or in a candle jar. But the other ones can be incubated at 37 degrees, and you can do Kirby-Bauer the same way. Okay, so strep, Neisseria, H-flu, and Neisseria gonorrhea, those have special requirements. Strep, you have to do your Kirby-Bauer on horse or sheep blood agar. They do exist. Neisseria has to be in CO2, definitely, and MH is Mueller-Hinton agar. Okay, plus 2 to 5% horse or sheep blood agar. GC agar base. Okay, gonococcal. There's specific agar. Usually it's modified Thayer Martin. When I talk about the Neisseria, I'm going to go over the media that is preferred media for Neisseria species. H. influenza, that's Haemophilus. We'll use Haemophilus test medium. And Neisseria gonorrhea, again, GC agar plus CO2. So that's just to illustrate that those organisms, the strep, Neisseria, H. flu, and gonorrhea have special media requirements. Okay. MIC, as I mentioned, is the minimal inhibitory concentration. It's the lowest antimicrobial concentration to inhibit visible growth. Okay, it's measured in micrograms per ml, and it correlates with the disc diffusion test. And it's developed to standardize the Kirby-Bauer sensitivities, and it's a serial dilution technique. Okay, so serial dilutions. So you're not going to be doing the tube method, but based on the different methodologies, you have plates that have MIC, like I said, is done with the tube method. And rather than doing tubes, you have these wells. It's a square plate with wells in it. And what happens is that the company will actually do the dilution of antibiotic in these wells. But so that you understand what's going on, you have different tubes. We'll do tubes, okay? So tube. So this is 1, 2, 4, 8, 116, 32, 164, 1 to 128. I'll stop here, 1 to 256. Okay. So let's say these are the concentrations of the antibiotic. So the antibiotic is diluted twofold across 9 tubes, right? Which tube has the highest concentration of antibiotic? The first one. So here, this has the highest concentration of antibiotic, and this one has the lowest. Okay, so here you have the company will give you these plates with wells with these dilutions of antibiotic. So what happens is you have a tube of organism, and into each well, this tube is has to be, and we're going to be doing this when we do the Kirby-Bauer, is 0.5 Mcfarland Standard. Have I mentioned that to you, the 0.5 Mcfarland Standard? That's the turbidity. That's the turbidity standard that we have to use to make our bacterial suspension. This is the 0.5 Mcfarland Standard. So when you make your antibiotic suspension, you need to match that. Again, that's CLSI standard. You can't just use a tube with turbid organism and then inoculate all those tubes. It has to be a 0.5 Mcfarland Standard. Okay, so you'll take 0.5 of this suspension into there, across all the tubes. Okay, so now you have organism into these tubes. So since this is the lowest concentration of antibiotic, will you get growth here or no growth? Say again? Probably no growth. You'll get no growth because you're right. This is the lowest concentration. So you get growth. Okay. This solution, you'll probably get growth. Okay. The concentration of the antibiotic is getting higher, correct? It's getting stronger, but it's not strong enough to inhibit the organism. So here you get growth. It's getting lighter. The growth is, it's growing, but it's getting lighter. And then let's say this is the last tube that's growth. And here, this tube is no growth. So this tube here, where this concentration is your MIC, the minimum inhibitory concentration that will inhibit the growth of bacteria. You see that? Lowest concentration, of course, you're going to get growth. Still low concentration, but it's getting stronger, but not strong enough to inhibit growth. Here, concentration is getting stronger, but you still see some bugs growing. Here, you barely see some bugs growing, and here, you don't have any more growth. So for here, of course, your antibiotic is the strongest here. You're not going to get growth. So you're going to get growth all the way to there, But since this is the first two, lowest concentration that inhibits bacterial growth, that's your MIC level. Okay, you all get that. Okay, that's MIC. So I'm going to be talking about later the MBC. That's MIC. If you have any questions, let me know. Okay. MIC agar version. Okay, so agar version is kind of labor intensive because now you have plates, actual plates with concentration of antibiotic, and you streak the organism onto those plates. And then you look for growth, no growth. So you have a lot of plates to deal with, if you can imagine. So it's labor intensive. It can test multiple isolates per plate, but you're using a lot of plates in this procedure. One or more isolates are tested. Plates are examined for growth. Spiral technique. We don't do the spiral technique anymore, but it's the highest concentration of antibiotic in the center, and you actually get a spiral pattern. So the highest concentration is in the center of the media, and then as you move away from the center, the concentration gets less and less. So you get a spiral pattern. We don't do this test very much anymore. Actually, I've never seen it. Automation. Okay, so you got three main companies. I'm used to using the Vitek. It's where it uses a vacuum to suck up the bacterial suspension into the wells of the card. Microscan takes your suspension and actually does pipetting. So Vitek uses a vacuum. Microscan uses a pipetting system. And I'm not familiar with the BD Phoenix, but it's also an automated system. Okay, so this is the MIC, right? So MIC by definition is the lowest concentration of antibiotic that will visually inhibit growth. So MIC is based on a visual observation. So for MBC, which is minimal bacterial concentration, what you do is, since this is your MIC, what you do is you take this tube, you can go as far as here to, let's see here. So what you do is you take this and you plate it. You take this and you plate it. You take this and you plate it onto probably blood or chocolate agar. You take this, plate it, and then we decided we'll stop here and plate it. Okay, so you got growth here. You got growth here, as expected. Here, you would expect you to get no growth, right? But you're going to probably get a few colonies here, okay? And here, maybe you'll get one or two colonies, and here you get no growth. This is your MBC, okay? That is your MBC, which is 1/4. You see how it's different than the MIC? This is your minimal bacterial concentration. And the MBC is the lowest antibiotic concentration that will kill 99.9% of the organisms. Because in the MIC, it's based on visual observation, but the MBC is based on actual culture of organism present. Okay, so the MIC is an approximation. The MBC is more accurate. Okay. Any questions on MBC? Was that clear? All right. Okay, so beta-lactam antibiotics. When I was a med tech student, I kind of had, well, I'll admit to it. I had problems distinguishing beta-lactam and beta-lactamase. Okay, the beta-lactam ring is the ring. It's the chemical ring that's present in the antibiotic. Penicillins have a beta-lactam ring. Okay, and then beta-lactamase. I thought beta-lactamase, is that in the medicine too? No. How naive I was when I was a student. Okay, I want you guys to understand too. Beta-lactamase is, the presence of beta-lactamase is a defense mechanism of the bacteria. An organism can have the enzyme beta-lactamase to fight against an antibiotic that has the beta-lactam ring. Typical antibiotics that have the beta-lactam ring are the penicillins, okay? The way the beta-lactam ring works is that it acts on the enzymes that link the enzymes of the peptidoglycan linkages, okay? So the beta-lactam antibiotic acts on the organism's peptidoglycan cross-linkages. You know that, right, from the Gram stain. The organisms that will, of course, you'll see them on the Gram stain. All organisms have the peptidoglycan cross-linkages. The beta-lactam will affect those cross-linkages, okay? So if the beta-lactam ring affects those cross-linkages, then the organism will not survive. It will not develop cell wall. Therefore, the organism will not survive. It'll die, or it won't even develop into an organism. So the beta-lactam ring is in the antibiotic. Beta-lactamase, okay, so a defense mechanism that the organism has, it wants to protect its peptidoglycan cross-linkages. So what it does, it has what's called beta-lactamase, okay? So that's its way of fighting back against the antibiotic. So when you have an antibiotic in the microbiology laboratory, and I don't think we'll be able to do any kind of testing, is that sometimes the doctor will ask, is it beta-lactamase positive or is it beta-lactamase negative? He wants to know if it's okay to give a penicillin type medication to the patient. Because if the penicillin that he's going to give to the patient and an organism is identified, if the organism is beta-lactamase positive, then the penicillin's not going to work. You see that? You guys all see that, Rudy? Okay, so if the patient's organism that you isolate is beta-lactamase positive, that enzyme will act against the beta-lactamase, it'll act against the medicine. Okay, so which has the beta-lactamase ring. So if it has beta-lactamase, giving penicillin is not going to work. So the doctor has to resort to a non-penicillin type antibiotic. Okay, do you guys see that? Okay. So the beta-lactam ring binds and inhibits the cell wall synthesis, like I just said, by binding to cross-linking enzymes in the bacterial cell wall, preventing cell wall synthesis. If this happens, the bacteria will not survive. Most bacteria cannot survive if they cannot produce a peptidoglycan layer. They won't even exist, because without that peptidoglycan layer, you got no bacteria. It's like us in our developmental stages. If we don't develop a head, then we don't live. You see what I'm saying? So another thing too is that bacteria may have what's called a PBP. A PBP It's a penicillin binding protein. So if the doctor is going to give penicillin, then the bacteria may have what's called, it's another defense mechanism to make sure that the bacteria will survive. It's called a penicillin binding protein, or PBP. It wants to survive. This is the beta-lactam ring. Again, the beta-lactam ring is in the penicillin type antibiotic, and that's what affects the enzymes in the peptidoglycan cell wall. The beta-lactam ring will attack the peptidoglycan cross linkages in the bacterial cell wall. Beta-lactamase is something that will attack the beta-lactam ring. So the antimicrobial agent in the bacteria, if it has beta-lactamase, again, beta-lactamase is in the bacteria. That's a defense mechanism against the medicine, okay, the penicillin. So it will inactivate the beta-lactam ring. If the beta-lactam ring is not working, then it won't hurt the bacteria. So beta-lactamase will inactivate the beta-lactam ring. I hope I'm not confusing you, because like I said, when I was a med tech student, I had to read this about 4 or 5 times. Even before I was teaching this class, I still had to read it a couple times. So I want to make sure you guys understand beta-lactam, beta-lactamase, penicillin binding protein, peptidoglycan cross linkages. You guys put it all together? You guys get it? Okay. You guys are better than me then. Okay, similar to cephalosporins, enzyme conversion, penicillin goes to penicilloic acid, cephalosporin goes to cephalosporanic acid, inactivates the antimicrobial agent. That's what beta-lactamase does. It will inactivate the antibiotic. We don't want an organism that has beta-lactamase. So the doctor's going to ask, can you do a beta-lactamase test? And that's because he's planning on giving a penicillin or a penicillin type antibiotic. Okay. So if it has beta-lactamase, then that means it will inactivate the beta-lactam ring. Schlichter test. Okay, so we have the MIC here. You have dilutions of antibiotic, and to those two dilutions, you're going to add a suspension of organism. The Schlichter test is kind of like the opposite of that. So remember I talked about peak and trough. Let me illustrate what I was talking about earlier. So you have 0 and then 12 hours later. So let's make this 12. 24. So dose is given here, 12 hours later, and then 12 hours later. So that's the terminology is you're giving antibiotics Q12 hours. So you're given antibiotics here. What happens is antibiotic level will go up, and normally it'll come down. Okay, you give antibiotics here again, it's going to go up, and it's going to go down. Okay, I intentionally didn't go down to 0 because I'm going to assume that this is an effective antibiotic. But if you draw a level here, let's say this is 30 minutes, I know it's not the scale, and you draw a level here, it's minus 30 minutes. This, right before this dose, this is called the trough, okay? You draw it here 30 minutes after the dose, this is called the peak, obviously because it peaked. What's valuable to the doctor is the trough level, because so you gave antibiotic, you gave a dose there. If it came here and it's still you still have a measurable level, then that might be appropriate for the antibiotic. This is the amount of antibiotic that will be acting against the organism. Like I said, if it's too high, it could affect the patient's liver. If it's too low, then it may not be effective. Say, for example, it diminished down to here. You do a trough level here, it's going to be 0. So between here, this point, and this point, what's happening? You're not protected. You don't have any measurable antibiotic level. So the pharmacy is the one, not the doctor, but it's the pharmacy who will determine whether or not to increase the dose so that you stay above, so that you have a measurable dose to affect the bacteria. If the patient's metabolism, like I said, is too high and it drops down to 0 before you do the trough, then between here and here, you're not protected. So what determines the dose of the antibiotic is actually the pharmacy. Okay, so in the Schlichter test, you draw 2 samples. You draw a serum, the trough level and the peak level. The peak level is 30 to 60 minutes IV. After 30 to 60 minutes, IV intramuscular, 60 minutes or hour and a half if it's oral. And then you draw a trough level. So you have 2 samples that are serum, okay? You have 2 samples that are serum, trough levels and peak levels. And what you do is, say for example, this patient has a positive culture. Let's say that it's a wound culture and the patient is growing E. coli. He wants to know if the antibiotic, let's say tobramycin, he wants to know if the dose of tobramycin is effective against the E. coli organism. Maybe the patient may or may not be responding to the antibiotics. So he could request a Schlichter test. So you take the organism that's isolated in the microbiology lab, you identify this patient is growing E. coli, okay, from the wound culture. You take that organism and you make a standard suspension. We'll do 0.5 Mcfarland Standard, okay? Now you have a standard suspension of organism. And so now you're going to be doing serial dilutions. Rather than doing serial dilutions of antibiotic, you're going to be doing serial dilutions of the patient's serum, okay, of the trough level and the peak level, okay? So those 2 samples, you do serial dilutions, the trough level and the peak level, and then you add your organisms to it, the actual organism that was isolated. And then you take a look at the growth. And the lowest serum dilution, similar to that, the lowest serum dilution that does not inhibit growth, if the lowest serum dilutions do not inhibit growth, then that means your therapy is not effective, because now you're getting growth in the lowest dilutions. You should be getting no growth if the antibiotic is negative. But here, the important thing to note is that the Schlichter test uses peak and trough samples of the antibiotic. So by diluting the serial dilutions, you're actually diluting the antibiotic against the organism. So you take the organism, standard solution, similar to the MIC, but now you're using peak and trough levels. So, and then when you look at your serum dilutions, you need to make sure that you're getting inhibition of growth. And if you're not getting inhibition of growth at the lowest serum dilutions, then your therapy is not effective. Okay, so that's the Schlichter test, peak and trough levels, patient serum samples. Indications for susceptibility testing. We actually talked about these three when I asked about it this before lecture. Make sure you know this for your quiz. So asterisk this slide. The three indications for susceptibility testing is you want to see how effective your antibiotics are. You want to help the clinicians make a decision on which antibiotics are best to use. And you also want to identify the organism. That's why you do susceptibility testing. Effectiveness of antibiotics, you're helping the clinicians and identify the organism. Okay, make sure you know that slide. The Kirby-Bauer sensitivity deficiencies, it's qualitative, but I think it's accurate. That's why the MIC is more commonly used. You can use Kirby-Bauer as a backup. It has some inaccuracies, some specific antibiotics, and also too, you can get contamination, like for example, Proteus. Proteus is a pain in the butt because it swarms all over everything. Antimicrobial selection, you want to make sure that the antibiotics that you use is in the hospital formulary. You don't want to use exotic antibiotics that are nice and sensitive, but if those antibiotics are not down in the pharmacy, then there's no point in using it. You got to make sure that the hospital has those antibiotics in inventory. The medical staff is, I talked about the antibiogram. The medical staff is interested in your antibiotic trends of which organisms are sensitive or resistant if they're isolated. CLSI is important because they're the ones that standardize the zone sizes and also the zone sizes for Kirby-Bauer. And for similar activity, if penicillin doesn't work, you need to use an antibiotic that has similar activity or inhibitory activity to an organism that it'll inhibit just like the penicillins do, but it's not a penicillin. Okay, so antibiotics, similar activity. Okay, so you're measuring the size of an area around a disc that prevents growth, the zone of inhibition. That's called the zone of inhibition. And it's measured in millimeters. And you do it across the disc. You want to do the maximum distance across the disc, which is right at the equator, right across the midpoint of the disc. And the zone of inhibition is based on previous MIC patterns. And that's, again, it's standard zone sizes of whether or not an antibiotic on the Kirby-Bauer is sensitive or resistant is based on CLSI standards, Clinical Laboratory Standards Institute. Kirby-Bauer principle. So it's antibiotic agar diffusion method. You have the filter paper disc impregnated with an antibiotic, and then you streak. What you do is on your plate, you streak for growth. So when we do the Kirby-Bauers, I'll show you how to streak for growth. You streak it 2/3 down, you turn the plate, you start again at the top, and then you streak 2/3 down, and then you turn it again, maybe 2 more times at the top, you streak it 2/3 down and another 2/3 down. You will get 100%. You want to get the organism on 100% of the plate. Again, this you don't just take any colony and grow it. You have to make a suspension a 0.5 Mcfarland Standard, okay? Because there are consequences if your suspension is too heavy or if it's too light. I'll get back. I'll get that. That's coming up in the upcoming slide. The Mueller-Hinton auger characteristics, pH is 7.2 to 7.4. And then there's the plate depth. So we'll be using the large plates, which is 150 millimeters. The plates, the standard plates that we use is a 100 millimeter in depth. 100 millimeters, but 4 millimeters in depth. And that's standard, 4 millimeters in depth. But the size of the plates, you have your 150 millimeter, that's your large plates, and the 100 millimeter smaller plates. But the depth is actually standard. It's 4 millimeters in depth. You incubate these. You want to incubate your plates before you use them 10 to 20 minutes to make sure that there's no growth, or you also want it to, you don't want it to be cold. You take it out of the refrigerator. You don't want to inoculate the plates cold. So you incubate it 10 to 20 minutes, kind of helping it get to ambient temperature, and also to evaporate excess moisture. The filter paper supplied in cartridges, you'll see those. Refrigerate these antibiotic discs 4 to 8 degrees centigrade, or if you're not going to use them for a long time, then you can freeze it at -20. You want to warm the antibiotic disc again prior to use, 1 to 2 hours. Make sure it's at room temperature. Okay, so here, that image is the Mcfarland Standard. Okay, so what you do, these are the Mcfarland Standards, and these are the background stripes that you'll be using. The Mcfarland Standard, if you can see the stripes, like if you look at the Mcfarland Standard, you can see this, the lines clearly, as opposed to the 1 Mcfarland Standard, the 2 and the 3 Mcfarland Standard. So they look differently. So what you want to do is you put it against this card here and look at the clarity of those lines. Another thing you can do, which is what I do, is I do a Mcfarland Standard, and I've done enough of the 0.5 Mcfarland Standard. It's like I memorize this turbidity, not too heavy, not too light. This is a Mcfarland Standard. Once you see this, once you match the Mcfarland Standard, then memorize that turbidity. Okay, 0.5 Mcfarland Standard. You take 4 or 5 isolates, make a suspension. If it's too heavy, then you add more saline. If it's too light, then add more colonies. Okay, so there's 2 ways to make your suspension. One of them is that you take organism and you put it in broth, maybe like a TSB, which is tryptase soy broth, and you bring it to log phase. When you bring it to log phase growth, you know what that means, right? When I say log phase is on the log curve. The growth curve is that the growth of an organism kind of starts when it's growing. It's pretty steady, and then what happens, it ramps up and it goes into a plateau and it comes down. This area here is log phase. So when you make your suspension, it's gonna, okay, so what the heck is going on? Oh, okay, I'm in TSB, nutrient media. I'm gonna grow. So when it's growing, this area here of the growth, this is the growth curve. Then you get the plateau, and then you get decline. This is log phase. Okay. So the organism is in log phase. So it's meaning that it's actively growing. That's optimal. You want organism that's actively growing. You can, and it'll take 3 to 5 hours at 35 degrees. So when you're on the bench and you decide, I want to use organism that's in log phase, you take some TSB, couple colonies, put it in your 37 degree heat block, and you let it cook. So once after 3 to 5 hours, then you're going to be pretty much in log phase. Okay, the organism is going to be actively growing. So you take a look at that tube that you put into the heat block, and at 4 hours later, so when you're on the bench, you identify your organism. Let's say you're reading plates. It's 8:30 in the morning, 9 o'clock in the morning. You take a colony, put it to TSB, and put it in the heat block and let it incubate. By 1 o'clock or 2 o'clock, that's when, usually after lunch in the microbiology lab, that's when you do your setups. Usually in the morning, that's when you do your reading. You read your cultures. Then once you're done reading your cultures, then you go to lunch, you come back from lunch, and then you do your setups. By that time, about 4 hours later, you'll go to your tube, and it's going to be more cloudy now because your organisms are now in log phase. Log phase. They're actively growing. Okay, so you take your tube, and it's going to be pretty cloudy. Then you're going to dilute it to the 0.5 Mcfarland. Okay, but now your suspension is actively growing, and then you'll use that 0.5 Mcfarland to inoculate streak for growth on your Kirby-Bauer plates, or not Kirby, your Mueller-Hinton auger plates. The method 2 is not doing the log phase. So say, for example, you're slow on the bench and you didn't read your cultures and you didn't identify the colonies that you want to work up because it's busy, and you identify the colony that you want to work up, and it's say at 11 o'clock and it's like, okay, I got to go to lunch and then come back. You can't, it's already too late to put the organism in log phase. So what you do is you take your colonies and you just add saline and make your 0.5 Mcfarland. Okay, a lot of times this is used commonly. Okay, like I said, it's optimal to use organisms in log phase, but you can make a straight suspension from colonies without having to be in log phase growth. You just do the same thing, make your 0.5 Mcfarland Standard, and then you can plate it onto your Mueller-Hinton auger, and then add your antibiotic disc for Kirby-Bauer sensitivity. Turbidimetric adjustments. Okay, if it's too heavy, if it doesn't match your 0.5 Mcfarland, if it's too heavy, you add saline or broth. Okay, if it's too light, then you add organisms. So I mentioned earlier, there's consequences of not adding saline or not adding organism. If your suspension is not enough, it's too light. So this is a 0.5 Mcfarland. If your suspension equals to like a 0.1 or 0.2 Mcfarland, where it's too light, then your zone sizes will be falsely large. Okay, if you think about it, you don't have enough organisms, therefore the zone size will be large. It's going to appear that the antibiotic is more stronger than the amount of organism there, so you'll have large zone sizes. On the other hand, if you use maybe like a 1 Mcfarland Standard suspension or 1.5 Mcfarland suspension, where you have too much organism in your suspension to set up your Kirby-Bauer sensitivity, your zone sizes will be too small. So think about it, you have too many organisms, it's going to be too crowded, therefore your zone sizes are going to be small. You're going to be asked this on a test or a quiz. So what's the effect of not enough inoculum, or what's the effect of too heavy an inoculum? So not enough will be a false large zone size, or too heavy of an inoculum will be small zone size. So as you can see, depending on the zone sizes, you can misinterpret sensitivity versus resistance. Okay, so it's really important to make sure that you're at 0.5 Mcfarland. So susceptibility testing, Use a sterile non-toxic swab to remove excess liquid from your suspension and use the 3-direction mat streak. I like to do 4. Again, you start at the top, you streak, it's like coloring the plate with a crayon, turn it about 30 degrees, streak it again from top to bottom, left and right, and then turn it again, according to this procedure, 3 times from top to bottom, just go 2/3 down the plate. And I like to do a 4th, okay? Start at the top and color it left and right. You don't have to be artistic left and right, just color it really quick, okay? And then after you're done streaking for growth, let it dry 3 to 5 minutes, no more than 15, and then you will add your antibiotic discs. Okay, use sterile forceps. What you do is on the cartridges, you push out the discs onto the lid of the agar plate. Okay, you're not gonna push it out onto the agar directly. What you do is you push out the disc onto the lid of the plate, and then take forceps and manually put the disc, take the disc and put it on the agar itself. We may or may not have dispensers, just like the picture right there. We did at one time, but I don't know if we have it. I'll ask Daniela, because what you can do is you can insert the cartridges in there, and with one push, then it'll dispense the discs onto the agar. I'll ask Daniela if we have those dispensers. Otherwise, if we don't, then you'll have to push the disc out onto the lid of the petri dish, and then use forceps to manually place it onto the agar. Okay. After you put it on the agar, you want to make sure you tap it for good measure that it will stick to the agar. Okay. And then when you incubate it agar up, invert it. Incubate it at 35 degrees overnight, okay? Avoid CO2 for incubation unless these are the special organisms, the Neisseria, the GC, Haemophilus, and Strep. Those need to be incubated in the candle jar or in a CO2 incubator. And then the next day, you're gonna see your zone sizes. And the way that person is measuring the zone size is, I don't like to use, so he's doing it this way. So the disc is here, the end of the ruler is here. And that's how he's measuring it. What I like to do is if I'm measuring the zone size, I like the end of the ruler to be here. And measure like from 1 to 3. So he's measuring from 0 to 2 or whatever. I don't like to use the end of the ruler for this end. I like to extend it out a little bit and start at 1 or 2. You see my preference? Okay. So observe for the zone of inhibition. You should know what that is by now. Measure the diameter, go across the disc, the middle of the disc. And like I said, I like to extend the ruler out a little and start at 1. I don't like to start at 0. Different types of media, Mueller-Hinton. We have Mueller-Hinton, use transmitted light, visual light used for, Mueller-Hinton's used for most organisms. Disregard tiny, so what will happen is you can get kind of like interference, different tiny colonies that'll grow. Ignore those, just focus on your zone size. If you do get a double zone, what happens with a double zone, that's where a new generation of the organism has developed. But so if that happens, you want to use the more restrictive zone, okay, or the inside diameter. The new generation of organism can be a little bit more sensitive, but we want to report out the most the most sensitive or the smaller zone size. Ignore the Proteus. If you are dealing with an organism that has Proteus in it, you just ignore the swarming and just go ahead and measure your zone sizes. Reporting. Okay, like I said, I'm going to be giving you a handout based on CLSI standards of the different antibiotics and its respective zone sizes. So you report susceptible, which is sensitive or inhibited, resistant, not inhibited, or intermediate. And that's also in the chart, sensitive, resistant, or intermediate. Like I said, if the patient is, for example, allergic to penicillin, the doctor will use a non-penicillin alternative. And if it's intermediate, that's what he will be using. So these are some Kirby-Bauer tests. You can see what resistance versus sensitivity. Just because the zone size is big, you can't just automatically say, well, that's the preferred antibiotic. Say, for example, this lower one here. That looks like it's sensitive, right? But the zone size may not be big enough. So according to your CLSI chart, this actually may be resistant. Okay, just because you see a zone size here, don't automatically say it's sensitive. You have to measure the zone and go follow your CLSI chart. If sensitivity is greater than 20 millimeters, this is not 20 millimeters, that's for sure. Something like this could be like 20 millimeters. And so if you're going to be measuring here, obviously you can't go here across this way. You'll have to go from end to end here in this direction. Okay. But again, if you see a zone size, don't automatically interpret that as sensitive. These with no growth are obviously sensitive. Again, you have a zone size here, measure it and refer to your CLSI chart. QC. Okay, when you use QC, again, you have to use the 0.5 Mcfarland Standard. That's part of standardizing this procedure. When doing QC, you have to use standard organisms. You can't just use any old E. coli that you isolated from a patient last week. Oh, well, I have E. coli right here. And let's do QC on that. You can't. You have to use what's called ATCC organisms. ATCC stands for American Type Culture Collection. So there's a giant warehouse where the laboratory will purchase these organisms because you will get that lot of that organism will have a standardized and controlled Kirby-Bauer result, okay? Make sure you know the 4 ATCC organisms used: Pseudomonas aeruginosa, Strep faecalis or Enterococcus faecalis, E. coli, and Staph aureus. Make sure you know that. That will be on the test. What are the 4 ATCC organisms? Pseudomonas aeruginosa, Strep faecalis, or Group D, Enterococcus, E. coli, and Staph aureus. And these guidelines are provided by CLSI. Again, CLSI is what's defining this procedure. MIC, that's MIC up here, minimal inhibitory concentration, qualitative dilution testing. Those are those plates I was talking about. So you get these plates from the company, and in these wells, you already have diluted antibiotic. You give, you make your 0.5 Mcfarland Standard, you put that into the machine, and it'll take from that tube and aliquot from that tube into the wells. The machine will aliquot the organism suspension into the wells. Then you incubate it overnight, and then you don't have to visually measure growth, no growth. The instrument will do that colorimetrically, or it'll measure turbidity, and then it'll give you and determine your MIC. Okay, so that's the automated method. inoculate, incubate, and interpret. It's really easy when you have an automated instrument doing it for you. MIC inhibition is clear. So if it's inhibited by the antibiotic, it'll be clear, but the instrument will tell you. Clear means no growth. If you have growth, you have turbidity, or there is a button at the bottom of the well. If there's no button at the bottom of the well, that means there's no organisms that grew. If you see faint haziness, then you disregard it. If you see a small button, then you may or may not disregard it. MIC is the first tube for no growth. First tube for no growth, and that's your MIC. Quality control, again, is defined by the Clinical Laboratory Standards Institute. This is called the E test. Okay, and that's where you have a strip. So in this type of test, you're going to streak for growth onto your Mueller, Hinton auger. Do it 3 times or 4 times. I like to do it 4 times to get a really good map of organisms. And then what you do, this test is, I want to say ampicillin, but I know it's not. It's probably amikacin. Either way, it's an antibiotic strip. And if you look at the top, it says 256, 192, 128, 96. Those are your different concentrations at that point in the strip. So as you can see, the antibiotics will diffuse out away from the strip. And as it gets less and less and less, it comes down to a point. That's why the antibiotic gets lower and lower. The lower the antibiotic, the more growth you'll get. Okay, so at the point where the zone of inhibition meets the strip, that's your MIC. Okay, so as you can see, it's probably at 38. Do you guys see that? Do you see 38? Oh. So 38 is right here. This would be your MIC. This is coming down here. Okay. That's the point where no growth starts. It's used to determine the MIC whether or not a specific strain or bacterium or fungus is susceptible to the action of a specific antibiotic. Okay, so it's a different way of doing MIC, and that's the E test. Okay, like I said, the antibiotic will diffuse out depending, and it will diffuse out a certain distance depending on the concentration of the antibiotic. So the highest antibiotic will have the highest distance away from the strip, and as the concentration of the antibiotic gets less and less, then you have a shorter distance of diffusion away from the strip. Okay, you guys know what the zone of inhibition is? What's the zone of inhibition? Maddie? Say again. With no, okay, okay. What's another name for antimicrobial agent? Antibiotic, who said that? Okay. In performance of a diffusion test, how long is the plate incubated and what do you observe? How long do you incubate it for? That's right. You know, the best way to say that, 16 to 24 hours is overnight. You incubate it overnight. And what do you observe? Say that again. Okay. Okay. What method of streak inoculation is used for modified Kirby-Bauer tests? What's the method of streak inoculation? Lori? Say again? The broth? Now, what kind of streak method are you using? How do you streak it on the plate? Are you going to streak for isolation? Anybody? Matt? Yeah, it's called matte streaking. I don't like to use that term. I just use, you either streak for isolation where you get individual colonies or you streak for growth. Okay, so you're actually streaking for growth. Okay. Okay. What are the 3 indications for susceptibility test? Remember, I told you to memorize those 3. What's 1? Jeremy? I was hoping you'd memorize it on the spot. Okay, Lori. Susceptibility. What else? Can you kind of turn up the volume? Okay. Did you get all 3? What is it? Yeah. Okay. All right. Make sure you know those 3. Again, this is probably on the review, but again, you'll probably see it on a quiz. Okay. The broth culture suspension of a test organism for use in a broth dilution and diffusion testing is adjusted to match the turbidity of which standard? Yeah, what Mcfarland? Okay. All right, 0.5 Mcfarland. And that's it for antibiotic susceptibility testing. Are there any questions? I used to think that this lecture was hard, but then I hope I made the points clear, especially with the beta-lactamase, the beta-lactam ring. Like I said, when I was a student, I got those 2 mixed up. I didn't know what was in the organism. I didn't know what was in the medicine until I just opened my eyes and read it about 4 or 5 times. But with you guys, I hope I explained it in depth enough that you got it the first time around. So beta-lactamase is in the bacteria. It's a defense mechanism against the beta-lactam ring, which is in the medicine. Okay. Beta-lactam ring is in your antibiotic. It's in the medicine. It doesn't want to be, the bacteria does not want to be treated. Therefore, it's going to defend itself by having those penicillin binding protein or having beta-lactamase. The doctor wants to know if the organism has beta-lactamase because he wants to know if the penicillin that he's going to give is going to work. Okay. Any other questions? All right. Okay, so tomorrow's quizzes, and then the quiz or your first exam next week. If you guys see tetrad, if I give you a case study, and then there's going to be a lot of biochemicals, and in the description of the case study, you see the term tetrads. What do? What is it automatically? Who? Micrococcus. If you see tetrads, There's only one organism that is tetrads in this whole semester, and it's Micrococcus. So I can say it's salt broth sensitive, it's catalase positive, which it is, it's coagulase negative, it's non-beta hemolytic, but I could also say if you see bright lemon yellow, okay, there's no other organism in this semester that's bright lemon yellow. If you see bright lemon yellow and tetrads, the only organism you guys need to be thinking about is what? Micrococcus, okay? It's not going to be Enterococcus, it's not going to be Streptococcus, it's not going to be Staphylococcus, it's Micrococcus. So tetrads in bright lemon yellow is Micrococcus. Okay, which agency is involved with packaging and transportation? You guys are mumbling. What is it? DOT. Okay. Do you know your BSL levels? How many BSL levels are there? 4. How many BSC levels are there? 3. There was one class that I had asked about BSC level 4, and they tried to answer the question, right? Obviously, they had trouble. You know why? Why is that? Because there is no BSC level 4. Okay, that's a trick question. I'll throw out trick questions like I did in hematology. All right. Make sure you know your different types of laboratory, your BSL level laboratories and your BSC safety cabinets. This agency is involved with waste and waste disposal. Which agency is that? EPA. Know your LRN levels. What's the lowest level? And what's the next level? Say it again. Reference. And what's the highest level? National. Okay, so in your homework, again, I'm really glad that you guys did your turned in your homework in by Monday. But in your homework, make sure you know the definition of those terms like prodromal, infection, epidemic, pandemic, etc. Make sure you know those definitions. Period of illness, definition of disease, colonization. Remember that colonization takes place on the skin, on the surface of your body. Make sure you know those terms. Okay, so what test is positive for all the Micrococcaceae? Name a test that's positive. Catalase? You said that, catalase? Okay. Name another characteristic of Micrococcaceae. It's not a test. Say again. A characteristic of the 4 species of Micrococcaceae. What are they? Well, what's one characteristic? Jane said it's catalase positive. What's another that's common to all of the 4 species of Micrococcaceae? Say again. Gram-positive cocci. That's it. Gram-positive cocci. Okay. So Micrococcus is gram-positive cocci, but it's in tetrads. Okay. All the others, the staph species are clusters. Okay. Staph species are clusters. So can you differentiate between Staph aureus? Tell me one way to distinguish between Staph aureus and Staph epi. Say again, Jane. Hydrogen peroxide? Oh, no, because none of staph species are not diplococci. You're getting into strep. There's no such thing as gram-positive staph that's diplococci. Don't ever say that again, okay? Don't ever say that again. How do you differentiate Staph aureus from the other species of staph? Coagulase positive, that's one. Okay. What is Staph aureus? Is coagulase positive. Okay, so if it's coagulase positive, it's Staph aureus, correct? If it's coagulase negative, what is it? Two others. What are the three others? Tell me. Only two others.
On the chart that you showed us, it was a factor coagulase negative with the ingredient.
No. Well, okay, so Micrococcus is out of the picture because it's tetrads.
So it would be staph epidermidis and
Staph what?
saprophyticus.
Saprophyticus. So how do you report that if you only have the coagulase test? Do you report it as Staph epi or Staph saprophyticus?
No, staph.
What do you report to the doctor? Say that again, Maddie or Jesse? CNS. You report CNS or coag negative staph. That's all you can do. And the doctor will say, okay, I know what a CNS is. It's coagulase negative staph. That means it's either Staph epi or Staph saprophyticus. How do you distinguish between the two? Novabiocin. Okay, and which is which? Resistant. Remember, S and R. S goes with R. So saprophyticus goes with resistance, okay? S goes with R. And what's the clinical significance of saprophyticus? Why do we want to know saprophyticus? What's the clinical significance? UTI in who? Males, young males? Young females. Okay. So you know the types of diseases that Staph aureus causes, right? Causes boils. It's actually the one that's found in pimples. Okay, Staph aureus is the bad guy. So it's found in like boils and carbuncles. You know, the swelling or bumps in your skin. Those are the boils and the carbuncles. And also too in females, the important thing is the toxic shock syndrome. That's Staph aureus. What's another thing that you can get Staph aureus from? Remember? What, say one more time. Yeah, specifically which one am I thinking about? It's a great snack. Miss Lori. Potato salad. So the next time you go to a picnic and you're bringing potato salad, oh my God, Staph aureus infection. That's why you got to make sure that that potato salad is refrigerated. Potato salad. So if you see on any test or case study, and I say potato salad, you don't have to read further. That's Staph aureus, okay? Staph aureus. Okay, the coagulase test. If it's coagulase positive, if you're suspecting a staph that's coagulase positive, you can call it Staph aureus, right? But if it's coagulase negative, do you stop on the slide and just say I have Staph epi or I have Staph saprophyticus or I have a coag negative staph? Do you stop? No. So you can probably say coag negative staph, right? Because on the slide it's negative, but you're not going to stop, right, Jazzy? What do you do? Which is, what method is that? The tube. So you do the slide. If it's positive, you stop because positive coagulase is Staph aureus. If you do the slide and it's negative, you don't stop because you can't, you only are testing for the bound coagulase. You have to make sure that there's no free coagulase. So what you do is you set up a tube coagulase test to identify any free coagulase. So with a negative slide coagulase, you don't stop. You proceed on to the tube coagulase, throw it in the incubator, and you guys did it last week. And you're looking for a free coagulase. And if that's negative, then you can report out coag negative staph. So you haven't distinguished between saprophyticus and epi because you didn't do the noble biasins. So at this point, you can just go ahead and report out CNS or coag negative staph. If the doctor wants to further speciate, then you can drop your noble biasin. And for saprophyticus, you know that it's resistant to noble biasin. Okay, on the OF test, unfortunately, we don't have that media, but if growth is near the top, what is it? An oxidizer. If it grows top and bottom, it's a, right, and if there's no reaction, then it's a non-utilizer. So if it grows up at the top, what type of organism is it? Is it obligate or facultative? Obligate what? Aerobe, because it grows near the top, okay? And does it oxidize glucose or ferments? Glucose. Oxidizes glucose. Okay, so this test is going to be on safety and micrococcaceae. Lectures 1 and 2 of safety and the micrococcaceae, which is the micrococcus and the 3 staph species. So for gram stains, at this point, at the end of the staph lectures, did I talk about pairs and chains? When I talked about gram stain, there was, the gram stain in micrococcaceae, it said gram positive cocci, and then the next one it said pairs and chains. I want to take that out, but it's pairs and chains that was in quotation marks. It's pairs and chains because remember, if you're making a gram stain suspension, you're using that loop to really mix up your organism, and you're doing this. So you're breaking up its natural morphology. You're going to get from clusters, you're going to get pairs and some chains there. So it's not real. The gram stain from a colony is not really the true morphology of the organism. If you want to know the true morphology of your organism, you need to do your gram stain from liquid media. Okay, do your gram stain from liquid media. That will give you the true morphology of the organism. So staph, micrococcaceae, there's no such things as pairs and chains. And if I'm talking about staph species, will you see tetrads? Lori, you're saying half no. Is it definite no or half no? What does tetrads apply to, Srey? Micrococcus. You see tetrads, micrococcus, no other organism, not even staph species. Okay, staph species will grow. It's not an obligate aerobe, it's a facultative anaerobe. That means it'll grow throughout the tube. It'll grow where there's minimal oxygen present. And if on the OF tube, if you get an oxidizer that grows at the bottom, is that possible? No, that's correct. It's not possible because if it's an oxidizer, it'll grow at the top. The microdase test is only good for one organism. You guys know what that is? Micrococcus. Micro, okay? Microdase is only good for micrococcus. And that's all I have for review. And that's all I have for lecture. Are there any questions? So today we have blood and McConkey agar. Everybody will take one blood, two bloods, and two McConkeys. And in each pair, you will treat for isolation, Staph aureus, and Pseudomonas aeruginosa. Okay. And then we'll do colony observation tomorrow. And that's it for lab. So take one McConkey, take one blood, and scrape for isolation. Organisms are right here. All right.
still gotta go.
Pipette.
Swab means.